Yes, very good morning to everyone. My name is Derek Avitegeka, and this morning we are going to be looking at another condition of the joints of the body. Like we have done before, we have finished our topic on gout. For those that haven't seen it, kindly go to our TikTok account, Dr. Derek, or you can type in Abitex Derek on our TikTok page, and we have this video, and on our YouTube account, that is Abitex Temple Derek. Today basically we are going to look at a condition that is called rheumatoid arthritis. Like we have seen before, arthritis, these are various conditions of the body, various inflammatory conditions of the joints. So that is arthritis, meaning arthritis is an inflammatory condition that is relating to the body joints. So this means that whenever we hear the word arthritis, we are trying to refer to the inflammation of the body joints. But then you realize we have various types of arthritis or arthritic conditions, and the one you are going to discuss with that is now rheumatoid arthritis. So as we are going to define rheumatoid arthritis is a chronic systemic inflammatory illness. When I say systemic inflammatory illness, what does that mean? It means it is of the body system, and we shall say it is rheumatoid arthritis is a chronic systemic inflammatory disorder that affects many tissues and organs: skin, blood vessels, heart, lungs, and muscles, but principally attacks the joints, producing a non-superactive, proliferative, and inflammatory synovitis that often progresses to destruction of the articular cartilage and ankylosing of the joints. So that is rheumatoid arthritis. It is an inflammatory systemic illness of the body. Rheumatoid arthritis, like we are saying, it is inflammatory and systemic condition that affects our body joints, and the main cause of this condition is an autoimmune disease. So rheumatoid arthritis is an autoimmune disease. When we say an autoimmune disease, it means the body produces antigens, or the body starts to realize certain body parts as antigens and produces antibodies to fight them, meaning there is no any external invasion of microorganism in the body, but it is the body that it is detecting body tissues or body cells as being antigens and produces antibodies to come and fight these antigens. So that is rheumatoid arthritis. It is an autoimmune disease, and it is a chronic systematic inflammatory disease, which when not treated earlier, it can progress to become a chronic illness. So basically we are going to find inflammation of one or two or more joints at various body joints. So we are saying that although the cause of rheumatoid arthritis remains unknown, autoimmunity plays a pivotal role in its chronicity and progression. Like I've said, it is an autoimmune disease. The body starts to raise itself as being hazardous or as being toxic or as being an antigen, and therefore it produces antibodies to come and fight these antigens, which ends up being a disease to itself. Then about 1% of the world's population is inflicted by rheumatoid arthritis, or it is affected by rheumatoid arthritis, though women 2 to 3 times more often than men, meaning this condition is more in female than in male. So this is rheumatoid arthritis, and it is most common in those age 40 to 70, but remember that but no age is immune. So just like we have said, it is more common in female than in male. So but we have told us that no age is what? Immune, but it is most common in female. Now, as we continue, let us see what is the pathophysiology of rheumatoid arthritis. When we say when we say pathophysiology, we try to mean how does the disease progress? How does the disease come to occur from just being a sign, from then to becoming an illnesses? Now we are saying, like we have said that rheumatoid arthritis is an autoimmune disease, meaning the body is fighting itself. Now, the unknown antigen that now the body is going to detect or produce and to detect this as being an antigen is going to stimulate a type of immune cells called CD4 and T lymphocytes. Now, CD4 and T lymphocytes are immune type of cells. When we say immune type of cells, it means their production is to work on body defense mechanism. So that antigen now produced is going to stimulate the production of CD4 and T lymphocytes. So the produced CD4 cells can also be called T helper cells. So the produced CD4 cells and T lymphocytes by the immune system of the body is going now to stimulate the production of macrophages, because you know macrophages are white blood cells, and white blood cells are specifically responsible for body defense mechanism. So the production, the antigens, the antigen that has been now produced is going to stimulate the production of the CD4 cells and the T lymphocytes. These T lymphocytes now activate or stimulate the production of macrophages to release interleukin-1 and the tumor necrotic factor. So someone will ask now, what is an interleukin-1 and what is a tumor necrotic factor? So an interleukin or interleukin-1 is a type of a cytokine. Cytokine, these are all inflammatory mediators or responses that the body produces in response to an inflammatory condition or a certain illness. So an interleukin type is a type of a cytokine that plays a crucial role in the immune system. And the tumor necrotic factor is a type of a cytokine that plays a crucial role in the immune system. So it is a protein that is produced by the various cells, including immune cells, and helps to coordinate the immune cells and helps to coordinate the immune response to infection, injury, or inflammation. So, meaning the interleukin-1 and the tumor necrotic factor, these are cytokines that are being produced in response to an inflammatory response in the body. So the macrophages are going to submit the release of interleukin-1 and the tumor necrotic factor, which we are abbreviating as the TNF. The release, then there we are going to there will be release of the rankel, which stimulates osteoclasts. We all know that osteoclasts are bone resorption or bone resorbing cells, or cells that help in bone resorption, leading to bone destruction. Now, someone will ask, what does the rankel mean? Over RANKL, what does it mean? So, rankel is a receptor. R stands for receptor, A stands for activator of nuclear factor, meaning rankel is a receptor activator of a nuclear factor. That nuclear factor now, in this case, is the kappa or kappa B ligand. If I try to give the SP of kappa is Ka Pa Ka double Pa B ligand. So That is now the RANKL, which is a receptor activator of nuclear factor, which is now kappa B ligand. Now, this protein plays a crucial role in the regulation of bone resorption and immune function. It is a member of the tumor necrotic factor also, and produced by the osteoblasts, stroma cells, and immune cells. So that is the RANKL, and it is a key regulator of the osteoclastogenesis. So osteoclastogenesis, that is the formation of osteoclasts, which are type of bone cells, which help in bone resorption. So I think now we connect now the pathophysiology. So the release there, then we are going to have the release of RANKL, which stimulates osteoclasts, leading to bone resorption. Now, we shall have now interleukin 1 and tumor necrotic factor stimulating synovial cells. Synovial cells, these are cells of the synovium or the synovial membrane, which is a membrane that surrounds the bone, the bones at the synovial joint. So interleukin 1 and tumor necrotic factor stimulates the synovium or the synovial cells, leading to synovial cell proliferation and formation of a panels. Now, a panels is an abnormal mass of a tissue. That is a panels. It's now a tumor or abnormal mass of a tissue now. So, synovial cell proliferation and formation of a panels, which now will result into production of prostaglandins. We all know that prostaglandins cause pain sensation, and we shall have and matrix metalloproteinases that causes cartilage destruction. So once we have now cartilage destruction, it means now we are affecting our joints, and the condition that is going to result now is now what we're calling rheumatoid arthritis. So that is the pathophysiology of rheumatoid arthritis. Just repeat, we have said rheumatoid arthritis is an autoimmune disease. And being an autoimmune disease, it means it is the body that is fighting itself. And for an immune system to take place, there should be an antigen and antibody reaction for us to have an immune reaction. Now, what is causing an immune reaction in this case is an unknown antigen that the body is going to produce and detect as being an antigen. So what happens next? Now the body has to produce immune cells to fight this antigen. So these immune cells that are going to be produced, so when we have studied, we shall have CD4, which CD4 cells we said can also be called the T helper cells and the T lymphocytes. These are immune cells. So these immune cells now are being produced in response to the unknown antigen. The CD4 cells plus the T lymphocytes now are going to stimulate macrophages to release anti-inflammatory mediators, interleukin 1 and tumor necrotic factor. We have already explained what is interleukin 1 and also what is tumor necrotic factor, what here we are abbreviating as TNF. So the macrophages are going to release interleukin 1 and tumor necrotic factor, which releases now RANKL, which stimulates osteoclasts, leading to bone resorption. Like we all know that osteoclasts are type of cells that help in bone resorption. Interleukin 1 and tumor necrotic factor now stimulate synovial cells or cells of the synovium or the synovial membrane, leading to synovial cell proliferation and formation of panels, a production of prostaglandins, which is a pain sensation, and matrix metalloproteinases that causes cartilage destruction. So the cartilage destruction now here becomes now results into that condition now we are calling rheumatoid arthritis. I guess now we understand. So that is how rheumatoid arthritis comes to happen. Now let us take a look at these three types of joints. One here we have, this is a normal joint. So in a normal joint, or what we call a synovial joint, we always have two articulating bones. We have the proximal joint, so the proximal bone, and the distal bone. The proximal bone articulates with the distal bone at the articular cartilage. This is what we call the articular cartilage. So we have an articular cartilage on the distal bone and an articular cartilage on the proximal bone. Then we have what we call the synovial membrane. So this is the synovial membrane, and these are now the muscles. So likewise, also on the left, we have the synovial membrane, what you can also call the synovium, and now the muscles. So this is our normal synovial joint. Now when we come to this bone, now we have another condition that kind of resembles rheumatoid arthritis, that is called osteoarthritis. So what is the difference between osteoarthritis and rheumatoid arthritis? In osteoarthritis, what we are seeing now, if you try to compare here, there is degeneration of the articular cartilage. That is osteoarthritis. Meaning there is going to be wear and tear. These two bones are going to keep grinding on one another, and then they will lose deformity and there will be wear and tear. That is osteoarthritis at a synovial joint. Then when we look at rheumatoid arthritis, we have the proximal joint bone and the distal bone. So we see here that here we have the articular cartilages present, and what causes now the pain and swelling at this joint is the inflammation of the synovial membrane. So it is this synovium here is inflamed, you can see it here, but here it was normal, as you see from a normal bone. If you try to compare a normal bone and the bone of osteoarthritis, but here we are, if you compare this bone of rheumatoid arthritis and on a normal bone, you see that here we have the synovial membrane in a normal shape, but here we have a synovial membrane which is inflamed. So that is how we can best differentiate between osteoarthritis and rheumatoid arthritis. Now when it comes to the toes in our hands, osteoarthritis mostly affect the proximal joints of the toes, or where the toes end. That's why we shall have osteoarthritis. So if we have pain and inflammation within those proximal ends of the joints, that is significance of osteoarthritis. And rheumatoid arthritis, mostly it is to the distal bones or the distal joints of the body. So we see now those two arthritic conditions, osteoarthritis and rheumatoid arthritis, and we can see what best differentiates or distinguishes them now. So if we are to continue, we are going to see the sequence of events. So proliferation of synovial membrane cells with inflammatory cell infiltrate. Then we shall have destruction of joints, and then finally disability. So after there is the proliferation of the synovial membrane, then we shall have inflammatory cell infiltrating, or having inflammatory cells being formed or produced at the synovium or at the synovial membrane. Next, we shall have destruction of joints. So if joints are distracted, you know what the function of joints, one, they help in movement, they help in motility. So if joints have been distracted, then we are going to have disability, meaning a person may not be able to move, may have difficulties in movement, or feels pain in movement. So that is the sequence of events when someone is suffering from rheumatoid arthritis. How do we diagnose osteoarthritis? For us to diagnose arthritis, we shall best depend on two key points, or two elements. One, we have clinical manifestations, and we can carry out certain investigations. So let us look at some of the clinical manifestations that we can have on our patient, or even you yourself, if you happen to feel or think you may be having rheumatoid arthritis. So some of the manifestations, one we shall have articular manifestations, meaning these are manifestations at the joint area of the body. So one, we shall have symmetrical peripheral polyarthritis. So symmetric peripheral polyarthritis, as well, the word symmetric means doubling or one equal on both sides. That is, so symmetric peripheral polyarthritis involves that if it is now at the knees, we shall have all the two knees involved, both the left knee and the right knee all inflamed. That is what we are calling now symmetric peripheral polyarthritis. Then we can also have morning stiffness, at least for more than 1 hour, whereby someone's joints feel stiff. If you squat, you feel unable to stand up again, or if you stand for too long on intending to stand up, you feel pain, mostly in morning hours. So those are the articular manifestations, though we also have what we have called here the extra-articular manifestations. And the extra-articular manifestations, now we have this one here is explained symmetric peripheral polyarthritis. This is which is 3 or more joints, like I've explained, 3 or more joints for more than 6 weeks. It can also be at small joints, that is at the hands, at the toes, and the feet, our toes on the feet. Then we also have peripheral to proximal, like we said, it is on the proximal part, and also leads to deformity and destruction of the joints. That is the symmetric condition, polyarthritic condition. Now, then the morning sickness, like I've already explained, is morning or after prolonged inactivity. It can be bilateral, meaning on one or two or parallel or two joints that are being affected, and it can be for more than 1 hour. Better with movements, like if you have been seated for so long, you may feel this stiffness. Maybe you have been seated for long, you have been sleeping, but as you keep moving, you feel pain as you start the movement. But as you go on, this pain may do what? May disappear or may get relieved due to movement. That's why I was saying that pain with the better with the movement, and then pain with the movement of the joint. So you always feel the pain when you are moving the joints. So that is that. So when we go to the physical examination, here we shall have decreased grip strength, because there is the degeneration of the joint bone extremity. So we shall have decreased grip strength. We have what we call the carpal tunnel syndrome. Now, the carpal tunnel syndrome is a condition that is characterized by pain and numbness or tingling sensations in the hand, and caused by compression of a nerve in the carpal tunnel at the wrist. Now, a scientist called Tunnel discovered this syndrome called carpal tunnel syndrome. Now, if you see on our hands at this area here, is where we have the carpal tunnel here. So at this area of the body is where you have what we call the carpal tunnel at this area here. So as well, it is a tunnel. What you can see, maybe it is a hole, or in Uganda you can say it is that is a tunnel. If I can try to demonstrate, that is a form of a tunnel, meaning in Uganda you can say it is omuwatwa. So it is a tunnel at the carpal area where various nerves, blood vessels pass together under a tunnel like this. So when there is damage to the median nerve in the carpal tunnel, it results into numbness within the hand, meaning someone can't control the hands. That is what we call carpal tunnel syndrome. So on examination, you can have carpal tunnel syndrome. resulting from the inflammation of the joints at the at the toes. So that's why we shall have carpal tunnel syndrome, meaning if you have inflammations within the toes, even where there is inflammation or the infection can spread to the medial nerves, hence resulting into the carpal tunnel syndrome. Next, we shall have ulnar deviation. When we say ulnar deviation, if these are the hands, we shall find when these hands are deviated like this. Find someone's fingers are too rigid. Find someone's fingers are too. If you can try to see from this video, that's the time of an ulnar deviation. So on physical examination, we shall also find someone's toes having that ulnar deviation. Then extra-articular manifestations here we shall have, meaning we shall have myalgia. Myalgia is muscle pain and stiffness, more associated to the point of the joint that is now being affected. Then we can also have what we call fatigue, feeling of tiredness, feeling of body malaise, that is fatigue. Someone feels as if he has worked for long or has worked a lot. So then we may also have low-grade fevers. Then we can also have weight loss and depression. Then we may also have anemia, that is low HB levels in the body, less than 11.11. Then we can also have rheumatoid nodules. Rheumatoid nodules, these are nodules that are going to be formed at the proximal ends of the joints. So we may find masses of abnormal bone growth at the joints that has now this rheumatoid infection. Those are the rheumatoid nodules. Then you can have a condition now we call pleuropericarditis. So when you hear the word, it is related to the pleura and also related to the pericardium of the heart. You all very know well that, or you may know well that the heart has its outer layer that is called the pericardium. So inflammation of the pericardium or the swelling of the pericardium is what we call pericarditis. Then if you have inflammation of the pleural layers, both the visceral pleura and the parietal pleura of the lungs, and the inflammation of the pericardium of the heart, meaning now two organs are affected, the lungs and the heart, the pleura of the lungs and the pericardium of the heart. So when they get inflamed or when they get diseased, this is the condition now we are calling the pleuro-pericarditis. So it can be also a manifestation of rheumatoid arthritis in advanced stages, or when it becomes now to chronic stages of rheumatoid arthritis. Then you can have neuropathy, that is affects now with the neurons or the nerves. You shall have scleritis. Scleritis, this is relating to the eyes, eye condition, or inability of the eyes to do what? You find that the eyes are inflamed, that is scleritis. And you also have splenomegaly, that is the inflammation of the spleen. You can also have vasculitis, which is the inflammation of the body vessels. So these are some of the extra-articular manifestations which can be our signs and symptoms of someone with rheumatoid arthritis. As we continue now, we shall look at what we call the rheumatoid nodules. Like I've explained, these are extensor surfaces, especially on the elbows. We may have specific, where they may be very specific. They only occur in 30% of patients with rheumatoid arthritis, and mostly in late stages of the disease. That's when we can have rheumatoid nodules. Now, certain investigations we can make here, we have what we call arthrocentesis. Arthrocentesis. So if you try to understand arthrocentesis, it is relating to the joints now. And if you know arthritis, we said the word arthritis results from inflammation of the joints. So if you look at arthrocentesis, most cases arthrocentesis is a medical procedure that involves the insertion is a medical procedure mostly that involves the insertion of a needle into a space to remove fluids. So we can do this procedure by trying to insert a needle at the joint that is suffering from rheumatoid condition, or that is affected with rheumatoid condition or rheumatoid arthritis, by inserting a needle into that joint space to remove fluids. That's now the synovial fluids now. So this helps to relieve pressure, or and also we can also inject certain medications that we can use to relieve this inflammation at the synovium. So that is atherosclerosis. Then we also have what we can do is arthroscopy. So arthroscopy is, as well as scopy, meaning it is a study or study of something. Scopy. So arthroscopy is minimally invasive surgical procedure that allows a health worker, especially now a doctor, to examine and treat joints and surrounding tissues using a small camera and a surgical instrument, and mostly used to diagnose and treat conditions such as osteoarthritis, rheumatoid arthritis, and injuries to the joints, and such as torn ligaments or cartilages. So we are now using a small camera to try to visualize what could be causing the condition of rheumatoid arthritis. Either you can evaluate ligamentous or cartilaginous integrity, or do a biopsy. A biopsy is taking a tissue for examination and try to really study it and make further investigations on it, what could be causing and the progression of this condition, rheumatoid arthritis. So this picture here shows us on a microscopic view what we call the rheumatoid arthritis cell infiltrate. So if you try to take an ultra scan or a radiograph, we shall see, oh, this now what we are calling the inflammatory cell infiltrate, these cells here. So when you take a scan, you shall have to visualize this on our radiographic chart. So laboratory investigations, you can do what we call a rheumatoid factor test. So the rheumatoid factor test, it is a test we are doing to determine the degree and severity of inflammation at this joint, and if it is positive, and it is always positive in 70 to 80% of patients. So if rheumatoid factor is positive, of course that confirms rheumatoid arthritis. And we shall also have immunoglobulin M and immunoglobulin G being high. So immunoglobulin, these are body globulin cells or immunoglobulins. So immunoglobulin M or immunoglobulin G may be high for someone who has rheumatoid arthritis. Then if immunoglobulin M is positive, more severe disease and poor outcome. In most cases, if you take an immunoglobulin M test and you find immunoglobulin M high, it is indicative or suggestive of more severe disease, meaning the disease is in the severe stage, and in most cases there is poorer outcome which may lead to disability. So it is always important for our patients to detect this and always seek immediate medical intervention to prevent the disease from propagating to advanced stages. Then we can also do an acute phase reactions or reactants, amongst which we can do what we call erythrocyte sedimentation rate. We can also what we call the CRP. CRP is creatine reactive protein. These are used just mostly for monitoring the disease activity. You know, well, in our body we have what we call creatinine phosphate, mostly stored in our body joints, and it's always used mostly for energy production. That is, if we go in a state of oxygen debt and our bodies are never to produce enough oxygen for aerobic respiration to take place in our body for us to breathe or act aerobically in our body. So we shall take erythrocyte sedimentation rate, which is ESR, and the CRP, just for monitoring the disease activity. Then we can also do radiography or radiology to evaluate disease activity and joint damage, and plain films and color Doppler, ultrasound scan, and magnetic resonance imaging to determine rheumatoid arthritis. So these two images here show us we have here a normal hand. As you know, now we have the toes. These are the normal bones. You see they normally aligned. So when you take a radiographical study, this is a normal hand. But when for someone who has rheumatoid arthritis, we have arthritis. This is here. There's an inflammation here. There's also an inflammation here. And you see how the joints are inflamed, or the joints are making the other one. We talked about what we call the ulnar deviation. So if you see the alignment of these 4 fingers, actually the 5 fingers, and also compare with a normal hand, this shows an ulnar deviation, which is now suggestive of rheumatoid arthritis. And also you can see how we have bone displacement. What is causing this bone displacement is what we have seen in bone destruction in the pathophysiology of rheumatoid arthritis. So see, when you look on this now, this other one has been of the hand, now this is of the toe now, or of the feet. So this is a normal feet with all the 5 toes of the feet well aligned. Then when you take a radiograph of someone with a rheumatoid arthritis, this is how to present. See now the joints, these are the bones, but then you see the curving, which is what we call now the ulnar deviation. And you see now the dislocation of the toes here. So it is not a normal alignment in human being here. So this is also suggestive of rheumatoid arthritis. So the disease severity, in most cases we shall have arthralgiasis, we shall have increased inflamed joints. That is, if in mild cases of the disease, we shall have mild functional limitations, meaning you can walk but you just feel some pain, somewhere you feel maybe you just feel mild pain. Then we can have minimally elevated erythrocyte sedimentation rate, and we should also have minimally elevated CRP, which we call the creatinine reactive protein. Then we have no erosions, no cartilage loss, no extra-articular manifestations. That's still in moderate case. We shall have 6 to 20 inflamed joints. 6 to 20 inflamed joints. That is if it is in moderate case. We shall have moderate functional limitation. We may have elevated erythrocyte sedimentation rate or CRP, radiographic evidence of inflammation. We may have no extra articular manifestations. That is for moderate case. We may also have, in severe cases, more than 20 persistently inflamed joints. In body we have seen we may have 6 to 20 joints that are inflamed. So in severe cases we shall find we have more than 20 persistently inflamed joints. We may have this may rapidly decline in functional capacity. Then radiographic evidence of rapid progression of bone erosion and loss of cartilage. And then extra-articular manifestations in severe cases. Then the bad prognosis, we shall have rheumatoid factor, which is positive. We shall have early development of multiple inflamed joints. We shall have severe functional limitations. We shall have lower socio-economic status and less education, persistent joint inflammation for more than 12 weeks. So that has been the severity of the case. So let us try to look at the management. How can we manage our patient who has appeared with what the disease now we are calling rheumatoid arthritis? So our management one, I'll try to minimize here so that we can all try to visualize clearly. Sorry, okay, so we move like this. Sorry, let me correct this again. So here we have some of the medications that we can use to treat our patient who presents with rheumatoid arthritis. After seeing all what rheumatoid arthritis is and what is contained in rheumatoid arthritis, so here we're going to see the medications now. So example of the medications now we can use here, the drugs we call the non-steroid and inflammatory drugs, or what we call the NSAIDs. NSAIDs, that is the non-steroid and inflammatory drugs. These ones are used to relieve pain and reduce inflammation. And examples of, we shall use here ibuprofen, which is the most drug on market. And prescription here we shall have ibuprofen that we shall prescribe to our patient 400 milligrams TDS for around 5 to 6 days, depending on the severity of the illness. We can also use corticosteroid drugs. The corticosteroid medications help reduce inflammation and slow disease progression. That's their main indication here, and they're used for short-term relief due to side effects with long-term use of the medication. And examples of the we can give prednisolone, we can use hydrocortisone, we can use dexamethasone. These are some of the corticosteroid drugs we can use, but the drug of choice here regard, we can use prednisolone, which is common in market and with minimal side effects. Then we can have disease modifying and rheumatic drugs, what we call the DMARDs. Now the DMARDs, mostly for them, their indication is to suppress the body immunity, because we have said what is causing rheumatoid arthritis is the immunity is increasing. That's why it is trying to affect its own body cells. So we give the DMARDs, the disease modifying and rheumatic drugs, to try to suppress the body immunity so that it slows down. Once the body immune system slows down, meaning it is not going now to produce antibodies to fight its own cells. And amongst these drugs we can have methotrexate, which is a drug of choice here. Methotrexate, we can have hydroxychloroquine and sulfasalazine. So methotrexate, the dosage you shall take 7.5 milligrams once a week, or you can also take it in 2.5 milligrams TDS once, 2.5 milligrams, that is 3 times a day. You take 2.5 milligrams TDS in a 24-hour, then you repeat after 1 week. That is for methotrexate. Then we also have biological agents here, and examples of biological agents. These ones we have, the biological agents, for them they target specific parts of the immune system that fuel inflammation. Examples include the tumor necrotic factor inhibitors. So these drugs are coming to inhibit the tumor necrotic factor, the one that induced rheumatoid arthritis. Another example, we have etanercept, we have adalimumab, and also have infliximab. So the drugs of choice here, we shall use adalimumab, and also we shall use infliximab. So adalimumab, initial dose of adalimumab here we shall use is 400 milligrams, which we shall give subcutaneously every other week, meaning we shall take it once a week, 40 milligrams subcutaneously. And we can also give a maintenance dose of 40 milligrams subcutaneously. So we give 40 milligrams of adalimumab subcutaneously. Then infliximab, is its initial dose we give 3 milligrams per kg IV. 3 milligrams per kg IV in weeks of 0, 2, and 6, meaning we take in the first day in the week, or first time of the week, that is at 0 week. Then we shall take after 2 weeks from the first dose. Then we also take at the 6th week of, that's the medication, the dosage of infliximab, 0 week, 2 week, and 6th week. Meaning if you take today Monday, you shall take another Monday after the third Monday now after 2 weeks. Then you also take another after the 6th week has passed, then you take another dose. Like you also, it is 3 milligrams per kg IV, that is infliximab. Now you realize most of these drugs have a longer gap in frequency of drug administration. This is basically because of the side effects, which side effects of most of these biological agents is hepatotoxicity. So in order to reduce the side effects of hepatotoxicity and kidney dysfunction, we give that space, and research has proven to be effective once given once a week. Another drug of choice we shall have the JAK inhibitors, that is the Janus kinase inhibitors. These ones target specific pathways that involve in inflammatory responses. Examples we have tofacitinib and baricitinib. Tofacitinib, I think these names look good to remember. Tofacitinib, baricitinib, methotrexate, sulfasalazine. We have tofacitinib, baricitinib. So they're good names really to remember, as far as if you really want to be a good health worker, you want to be a good doctor, a good nurse, a good clinician, name it also. The JAK inhibitors, now here we shall have tofacitinib and baricitinib, and the initial dose of tofacitinib is 5 milligrams BD and the maintenance dose of 5 milligrams. And then the baricitinib we have 2 milligrams or 4 milligrams OD and a maintenance dose of 2 milligrams. So those are the medications that we can use for management of this patient. So I think now we said we can manage our patient. We have said we can manage our patient using corticosteroids, anti-inflammatory, non-steroidal anti-inflammatory diseases. We can use biological agents like adalimumab, infliximab. We said we can use JAK inhibitors, where we talked about the tofacitinib, and baricitinib. And besides that, we can also have other treatment remedies. We can have lifestyle modifications and non-pharmacological. We can have physical exercises. We can have lifestyle modifications. There could be a surgical procedure to be done to reduce maybe those rheumatoid nodules, and also regular monitoring of our general health. So I want to end this lecture by really thanking everyone for taking your time to listen to this audio. I remain, my name, I'm Derek Tegeka, and I'm proud to have you on my channels. Kindly let us follow for more studies. For more information, my contacts are on this tab down there on the comment section. My WhatsApp number is 07783555172. You can also contact me on 0759192193 or inbox me in my email address is abitexderek@abitextemboderek.com. So for any comment, for any correction, I come it. Let us grow together in the field of medicine. Wish you all the best. Thank you.